This program is presented by University of California Television. Like what you learn? Help others discover UCTV podcasts by leaving a comment or rating for us in iTunes.
So almost every year I present you a summary of our current research. And so I'm going to do it the same. I thought for the first slide that would be a tiny bit playful. I wanted to sort of compare, producing a great wine to a clinical research trial. And I realized that, the vintners has lots of challenges: the weather, the rain, the pests, the birds that come and nibble on the grapes. And I felt, that when I do a clinical trial these days, I'm dealing with the same challenges. It's getting worse. IRBs are getting more difficult. There are newer committees that want to look at your design of the study. There is a committee on the Medicare cost analysis to make sure that all the budgets is in the right place. There is a nursing committee that has to also approve your clinical trial, and so on and so on. I think when I retire, I may be more successful, and I may have an easier time planting grapes and making great wine than these days getting a design of a trial and finishing it and sending it for publications. So I don't want to go over a litany. I know most of you, whenever I talk to you every year, like to understand the mechanism of action of the drugs and why and the rationale, rather than going through a litany of all the studies. So I want to briefly, though, summarize 3 areas that I'm going to discuss. One of them, where we're putting emphasis, is to optimize the outcome with co-stimulation blockade. The number 2 is UCSF is really entering a new era of modulation vis-a-vis the allograft with Treg infusions. And then since most of you see patients with FSGS, I wanted to give you an update on this whole issue about podocyte injuries and all the newer mechanism of actions that have been published lately. So, belatacept, when it was approved a couple of years ago, was looked upon as a breakthrough drug because it did inhibit a very critical pathway in the activation of the immune cells. And it had many of the characteristics of what we would be considering as desirable for a great drug. It improves sustained improvement in GFR, it decreased development of donor-specific antibodies. These days, late after transplant, half of the kidneys are lost because of antibody-mediated rejection. Lower risk of cardiovascular disease. Well, half of the patients who lose the graft because they die prematurely from cardiovascular events. Improved compliance, a major problem. I mean, every few weeks we have a patient who's admitted with rejection, frequently irreversible rejection because of non-compliance. And of course, once you address many of these factors, you do have the potential of increasing long-term survival. However, I think if you see many of your patients who come back after transplantation, and you see them in your clinics, you notice that many of them are still on CNI. So in many ways, belatacept has not yet fulfilled its potential as a transformational agent in the transplant field. And just very briefly again, to refresh your memory, that activation of the T cell requires 2 signals: signal 1, which is the antigen, and signal 2, which is through the co-stimulation pathway. And if you don't deliver to the T cell co-stimulation, only antigen, the T cell doesn't get activated, it doesn't proliferate, doesn't produce cytokines, and undergoes apoptosis. And belatacept is a second-generation CTLA-4 Ig. a receptor fusion protein that binds with high affinity to the two ligands, CD80 and CD86. They also are referred to frequently as B71 or B72. And therefore, co-stimulation with CD28 does not occur. So this is a protocol of the two phase 3 trials that registered the drug. One was called BENEFIT, and it enrolled patients who received standard criteria donors or kidneys from living donors, and the BENEFIT-X that enrolled patients who received ECDs. I'm showing you the two main components of the trial: the patients who were on cyclosporin as the control arm, and the patients who were treated with belatacept. This is the lower intensity regimen that got approved by the FDA. And all patients received induction with basiliximab and an anti-IL-2 antibody and were maintained on MMF. So this is one of the trials. I don't have enough time to show you all the specifics, but with belatacept lower intensity regimen, while the efficacy failure, which take in consideration patient death, graft loss, loss to follow-up, was comparable in the two groups, but the belatacept patients had, as you can see here, a high rejection rate. What also was important that when the patients had rejection, histologically with belatacept, the rejection were more severe. And this is a projected graph half-life. This is based on the risks of the patients and their several factors that include age, GFR, et cetera, that at 3 years, when this group compared patients on belatacept versus cyclosporin, on a risk-adjusted model that they had developed, they could predict that over the subsequent 7 years, that the patients treated with belatacept would have 2 extra years of graft half-life, which would be an important prolongation. Now, why hasn't then belatacept fulfilled the promise? Okay, there were more PTLD in the phase 3 studies, but the PTLD were predominantly due to the fact that if the patient was EBV negative, the risk of PTLD was actually 8%. So now, when the FDA approved the drug, and of course, when any transplant physician chooses to use this belatacept, it's only in patients who are known to be EBV positive. Number two, of course, is the IV administration. I mean, it's a tiny bit more difficult to arrange for somebody to have IV drug rather than just writing a prescription for a pill. This is the positive side of the IV administration. It does actually firm up your control of compliance. And I think this is still a more positive than negative. Number three is the cost. I think we're becoming all more aware that when we prescribe drug, we need to also understand what is the cost. And the cost of the direct cost of belatacept are greater. I mean, the whole issue is longer term. If you do decrease cardiovascular events, if you do prolong graft half-life, if you do improve GFR, is then the cost fully justified? But I think that one of the important determinant that has discouraged the use of belatacept has been the higher rejection rate. More importantly, maybe that when it happens, it's histologically more severe. It's not antibody-mediated rejection, mind you. In fact, antibodies, DSA are decreased with belatacept, but histologically there is more severe cellular rejection. And so I think we're starting to understand that co-stimulation blockade is just much more complex than just looking at CD28 and CD86 or B71. As you can see here in the slide, when you look at the effector cells and the antigen-presenting cell, that that while belatacept binds to the B7 and doesn't allow them to interact with CD28, it also doesn't allow the negative pathway, which is PDL1 and CTL4 that binds to B7-1 and B7-2. Also, they will not be able to be activated. And the negative pathways are, in some instances, very important. And therefore, not activating the negative pathway could be in some ways as important as the lack of activation of the positive pathway. For example, ICOS ligand can bind to CD28 because it's not bound to belatacept. So there could be other pathways in the co-stimulation system that could activate the T cells. Now, we are also now understanding that Tregs will be impacted by belatacept therapy. Now, the Tregs depends on activation of CD28 when it binds to B7-1 and B7-2. CD28 is important in the fitness and survival of Treg cells, and the same receptors that induce negative signaling in the effector cells play an important role in the Tregs because if you inhibit their activation, you reduce the suppressor activities. To make potentially matter worse, when we designed the phase 3 trial, we use as induction therapy basiliximab, which is a chimeric antibody to the CD25 receptor. And the CD25 receptor is also an important pathway for the activation of Treg cells. So all in all, I think the type of regimen that was used may have resulted in this greater severity of rejection. So one of the efforts at UCSF has been to look at the drugs, see how they work, understand the regimen, and try mechanistically to put together a regimen that improve the efficacy of co-stimulation blockade. And for standard of care, this is a project we worked together with David Warshawski. We put together a regimen that we have used so far in maybe 24 patients that is supported by excellent data from primate studies. In primates, what they have found is that if you get rid of memory cells and if you treat the non-human primates with an mTOR inhibitor, that there is great synergism with co-stimulation blockade. So our current protocol, a patient who gets belatacept at UCSF now, is treated with thymoglobulin and not basiliximab induction. Is treated with the belatacept, that this is a lower intensity regimen. We use either 5 days of steroids or we continue steroids depending on the patient. And then we use CellCept the first 4 weeks, mycophenolic acid, until the patient has completely healed. And after that, then we convert them to everolimus, an mTOR inhibitor, to basically reach out to that synergism that has been reported in several animal models between co-stimulation blockade and mTOR inhibitors. And I think so far, at least from our experience, we've had, actually in the patients who have been exactly on this protocol, we have had no rejections. We're also, and this is a study run by Peter Stock and Steve Tomlanovich, we're participating with Emory in an NIH-sponsored trial, again, to examine various regimens with co-stimulation blockade. Group 1 is the control arm. Group 2 get thymoglobulin, just like our standard of care, but they're maintained on MPA, and then they have steroids withdrawn. Group 3 is sort of a novel approach. And one of the cells that can undermine co-stimulation blockade and result in rejection is memory cells. And the calcineurin inhibitors are known to inhibit the activity of memory cells. So in group 3, we do treat with basiliximab induction and maintain patients on MPA. However, we place the patients on tacrolimus for 20 weeks, and then we discontinue tacrolimus. The thought here is that we neutralize the memory cell long enough until the threat of rejection is gone. On a personal basis, I like to sort of look at the next wave and see whether we can combine belatacept with the novel agents that truly mechanistically and experimentally show synergism And one pathway that seemed to fit nicely with co-stimulation blockade is the CD40 ligand studies. Many years ago, we had an antibody against CD40 ligand, which was associated with thrombotic events because CD40 ligand is expressed on platelets. So now most of the attention has been focused on CD40 that is not expressed on platelets. And as you can see from this figure, the CD40 ligand CD40 pathway plays an important role. Of course, it's been known for a long time that's important in activating B cells, inducing antibody production, and so on. But it also, through the T cell, this pathway in the T cell plays an important role in upregulating CD80-86, so it helps drive co-stimulation pathway in the T cells. And also the macrophages, monocytes, have CD40 ligands on their surface, and therefore, when they're activated, they release cytodestructive cytokines. So inhibiting this pathway is important. And so we go back to a Nature article, which is really one of the important articles in experimental transplantation from May 1996. Chris Larson and Tom Pearson showed that if you block both CD40 and CD28, you can induce permanent graft engraftment. And these are mice transplanted with skin, and the combination of using CTL4-IG, which is the first generation belatacept, plus MRI, which is an anti-CD40 ligand, was the only regimen that induced indefinite graft survival. Similar studies, not inducing tolerance, but resulting in excellent graft survival, has been shown in non-human primates with both islets and kidneys. So combining these two agents could actually result in the type of excellent engraftment that we're after. And now we have one antibody in clinical trials called ASKP1240. This is a fully human antibody from Astellas. It's an anti-CD40 that is being tested in transplant and autoimmune diseases. Again, so when we would administer ASKP1240, it binds to all these CD40s and blocks B cell activation, T cell activation, macrophage activation. So you can see it has widespread potential to be very effective. And this is the first trial in which we gave one dose to look at pharmacokinetics. And what we found that with the 200 and the 500 milligram dose, we could induce prolonged occupancy of the CD40 receptor on B cells. The nice thing about this agent also, it did not induce depletion of B cells. And I think sometimes there are advantages in non-depleting certain cells because you run then lesser risk of opportunistic infections or PTLD. And now this is a large phase 2b study that ASKP is being tested in. Now, it's interesting that other companies also are getting into this anti-CD40 game. Novartis has a fully human anti-CD40, OM111, and I think they have already done a phase 1 in normal volunteer. And Bristol Myers has, in fact, a couple of antibodies, both newer antibodies to anti-CD40 ligand and CD40 antibodies. So, you know, I think this whole concept of combining belatacept with anti-CD40 may be coming to the forefront in the not-too-distant future. The other interesting molecule that I think has promise in terms of combination with the co-stimulation blockade is the IL-6 receptor pathway, which is well known to rheumatologists because inhibition of that pathway is an approved therapy in rheumatoid arthritis. So frankly, the IL-6 is a really interesting cytokine. It's produced by a number of cells. And it produces multiple effects on macrophages, B cell. It differentiates T cells into the effector Th17 cells. It affects endothelial cells. And the IL-6 it circulates, binds to the IL-6 receptor on the surface cell membranes. The problem is the IL-6 receptor doesn't have a cytoplasmic tail, so it doesn't signal. So the IL-6 receptor combo has to bind to two GP130 molecules, which then produce a signal inside the in the membrane and activates downstream signaling and so on. Now, what is more interesting, though, is that few cells actually express the IL-6 receptor. However, metalloproteinases cleave the IL-6 receptor, and therefore there is a lot of IL-6 receptor and IL-6 in circulation. And so the receptor and IL-6 can bind to all the other cells that express the G3-130. And almost all cells and all organs express these molecules. So this so-called trans-signalings expand IL-6 responsiveness to many cells and many tissues. One example that IL-6 responsiveness is present on tubular cells. And so this is probably through renal tubular cells. So this is likely to be through trans-signaling. Now, tocilizumab is a humanized antibody that binds to IL-6 and therefore affects the signaling from the IL-6 receptor. Sorry, it's an antibody to the IL-6 receptor, so it affects the signaling of IL-6, the pathway. And tocilizumab has been approved for use in rheumatoid arthritis. So this is a study in mice. It shows the potential. Now, of course, now we always tend to be skeptical about results in mice. In this study, mouse that received cardiac transplant, whether wild-type mice or that were IL-6 not out mice, rejected their heart very quickly. Wild-type mouse, however, that received CTLA-4 Ig had an increase in graft survival. It was good, but not that great. However, the IL-6 deficient mouse, when they also received CTLA-4 Ig, had indefinite graft survival. This is one study. There are many others that suggest that when you inhibit both the IL-6 pathway and co-stimulation, that you may actually induce excellent engraftment. And do we find IL-6 in rejecting kidney? These are studies that we've done with Zoltan and Lassex when we've taken kidneys that were normal and we did in situ hybridization for IL-6. We don't find any. Patients who have like borderline rejection, they have few dots. These are very few IL-6. Patients with rejection, though, this is A and B, we see much more in situ IL-6 production here. These are in inflammatory cells, and these are in retubular cells. And when we combine in situ hybridization with immunofluorescence, where we actually can see every structure, then we can determine more exactly that for example, that these IL-6 are present in renal tubular cells, while these are in inflammatory cells. So we can actually pinpoint the origin of the IL-6 cytokines. So this is a study we're about to start to test the effectiveness of IL-6 in patients who have inflammation. So as many of you know, at 6 months, we get a biopsy on all our recipients. We refer to these biopsies as management biopsies because, in fact, upon the finding of these biopsies, we may change the immunosuppression regimen. And so very frequently, we do find inflammation or borderline rejection, and nobody knows how to treat these inflammatory infiltrate, but there have been reports that patients who have inflammation in the kidney may have declining GFR in the subsequent years. So in this study that we're about to start, and we got the grant from Genentech for the study as well, drug, we're going to be randomizing patients in 2 groups. Some will treat with IL-6, the other one will follow a standard of care, and then all these patients get rebiopsied 6 months later to see whether we got rid of the rejection. And this is a follow-up study that we hope to start next year. Basically, a similar study with the tocilizumab, but here we want to add a twist to it, and what we want to do is use stratification on the basis of a common rejection module that Minnie Sarwell has described. So we add personalized medicine in the way we treat this entity, the borderline rejection. Now, so I think the time has come possibly to start considering a combination of belatacept and IL-6 blockade once we have enough safety from our first study. A few words about Tregs, because UCSF is embarking on several studies on Tregs. The Tregs are a small subset of T cells, maybe around 5%, and they can be distinguished by a variety of markers. The main function of Tregs is suppress the immune response by either preventing unwarranted immune activation or by resolving the immune response to limit collateral tissue damage. We know that loss of Tregs due to, for example, FOXP3 mutation leads to lethal autoimmunity in early life if untreated. And this is just a figure to show that Tregs play an important role in homeostatic control when there is damage or when there is a breach of the immune homeostatic status. And very importantly, they play a role in so-called infectious tolerance, meaning that regulatory cells promote a regulatory milieu so that they can expand the network of Tregs, again, in an effort to control effector cells. So there are 2 types of Tregs. There are natural Tregs. These originate in the thymus. And then there are the induced Tregs. And the induced Tregs tend to be induced in the periphery and tend to be more antigen specific, and they're utilized to expand the reach of the natural Tregs. This is a study in mice with islet transplant showing the effect of 2 types of Tregs, the natural Tregs, what we call the polyclonal, versus the donor-specific, antigen-specific Tregs. And as you can see, the top 2 figures, if I have here, if you get excellent graft survival if you use 25 million polyclonal, but you almost get similar survival if you use only 5 million donor antigen-specific Tregs. If you use 5 million polyclonal, graft survival decreases quite a bit. However, all these improved survival depend on giving concomitantly drugs that produce depletion of conventional Tregs or conventional T cells or effector T cells. So you just can't infuse Tregs in an experimental animal and expect the right outcome. You have to modify the immune system. And the first graphs here with poor outcome, this is infusion of Tregs in animals that have not had depletion of T cells, for example, with cyclophosphamide. So I think this puts in perspective that there is a certain balance that you need to deplete the effector cells so that the Tregs can actually function at maximum efficacy. So several trials at UCSF. We're about to start a pilot trial in 3 patients at 6 months who have inflammation. We get the blood. We take a unit of blood. We isolate their Tregs. we expand them, and this is now in only polyclonal Tregs, and then we reinfuse a couple hundred millions. This is what the FDA is allowing us in this study. The one study is a study that Dr. Kang is going to be conducting. This is part of a European network of studies called the ONE study. And here the purpose is to infuse Tregs, which are antigen-specific at the time of transplantation. And finally, we hope next year to start a more ambitious Treg trial, whereby we will take patients at 6 months who have inflammation or borderline rejection, and then infuse them either with polyclonal Treg, basically non-specific Tregs, or antigen-specific Tregs. And then rebiopsy them at 6 months and see which of these Tregs are more effective. Because we can actually stain these Tregs or utilize these Tregs with heavy hydrogen deuterium, which is not a radioactive isotope, we can infuse Tregs and biopsy the kidneys, let's say 2 weeks later. And in fact, by mass spec, we can detect whether the infused Tregs have gone to the kidney. So this study will look at the feasibility and see whether, in fact, Tregs can control inflammation. And the number 3 question that we need to answer is whether antigen-specific Tregs are superior to non-specific Tregs or polyclonal Tregs, because the antigen-specifics are more difficult to prepare. We have to get B cells from the donors, so this study is going to be done only in living donor transplant. And so it would be more streamlined, probably much cheaper, if the poly-Tregs behave or are as efficacious as the antigen-specific Tregs. In the last few minutes, I want to give you a follow-up on a topic that I'm sure all of you have been following over the past year as to what is the pathogenesis of FSGS. And as you remember, in a very important article in Nature Medicine was published that the circulating factor of FSGS and recurrent FSGS has been discovered, and it's a urokinase receptor, the urokinase plasminogen receptor. And the urokinase plasminogen activator receptor consists of 3 chains, D1, D2, D3. It doesn't on its own produce any signaling, so it has to bind to ligands. So of course, one of its substrate is urokinase plasminogen activator, resulting in plasmin, ECM degradation, motility of cells, and this whole pathway may be important in cancer. But at the same time, the urokinase plasminogen activator receptor can bind to the beta-3 integrin. And this is the pathway which results in the podocyte in changes in the cytoskeleton. And so if you look at the slide, you see that when SUPAR, and this is the urokinase plasminogen activator receptor, binds to the beta-3 integrin, it activates the so-called GTPases. These are the master regulator of the actin myosin cytoskeleton of the podocyte, and increases their motility. That's why they efface and they produce proteinuria. And the data from the primary author of the study was really very exciting, because it showed that only patients with FSGS had high level of SUPAR. This was not related to proteinuria. Other proteinuric glomerular diseases did not have high SUPAR. And when they compared patients with recurrent focal and non-recurrent focal, there was higher levels of FSGS in the recurrent versus the non-recurrent. So this seemed and then they paired this with a number of experimental studies that produce convincing evidence that SUPAR is that circulating factor. But you know, life is never as simple. And sure enough, there have been a number of publications. KI just recently had maybe 3 articles that were by different centers, different investigators, did not find that SUPAR was a marker of FSGS. First of all, many found it elevated in different diseases. One publication found it elevated both primary and secondary FSGS. And so we looked at our own data, and we initially did ELISAs for intact SUPAR. As I said, it has 3 chains. And as you can see from this, from this figure, we looked at normal control. These are patients without ASRD. But then we compared glomerular control, IgA, polycystic kidneys, recurrent, non-recurrent, and we did not really find difference in SUPAR levels. But because we knew that there is cleavage of the SUPAR molecule, and it can circulate either as the entire molecule or as 2 other molecules, the D1 and the D2, D3. So we developed ELISAs with antibodies specific for D1 and D2 and D3, because there were some reports that maybe it is the fragment D2, D3 that binds to the beta-3 integrin that is the cause of the activation. And again, when we ran these ELISAs, we found no difference with D1 between FSGS, recurrence, and non-FSGS. And again, here, comparing looking at the D2, D3 fragment, we do not find differences between recurrent, non-recurrent, and glomerular controls. So, I think this whole story with SUPAR seemed to be more complex than what had been reported. And it's possible that SUPAR may have nothing to do with FSGS or recurrent FSGS. So just recently, and this is something that, of course, it's of interest to us because of our studies with co-stimulation blockade. Abatacept, which is a first-generation belatacept, it's CTLA-4 Ig, was found to be effective in proteinuric kidney disease patients because they upregulate B7-1 on their podocytes. And so the whole thinking behind this is that the beta-1 integrin, which is important in the integrity of the podocyte, is activated when there is a high molecular weight cytoskeleton protein, talin, that binds to the B1 chain. B7-1, if it's upregulated by some mechanism on the podocyte, it binds to B7-1 and doesn't allow talin to bind to it, and therefore it disrupts the activation of the beta-1 integrin and leads to the fusion of the podocyte, effacement of the podocytes, and proteinuria. And so these investigators had 4 patients whom they biopsied who had FSGS, who had B7-1. I mean, this is it's CD80, basically, just as a reminder. And when they treated them with abatacept, their proteinuria got much better. So they kind of linked the pathogenesis of FSGS with a completely different pathway. And now, at this point, we have no idea how B7-1, beta-1 integrin relates whatsoever to SUPAR and beta-3 integrin. However, when you look at the data in their paper, it looked like most of their B7-1 staining occurred, or the most prominent B7-1 staining occurred in patients with membranous nephropathy, and not as prominent in patients with FSGS. I mean, it's there, as you can see, but it's not as prominent. So the investigator, this is their hypothesis, that you may have a circulating factor. It could be SUPAR, we don't know. It could be something else. It produces glomerular injury. And the podocyte then upregulates B7-1, loses B1 integrin activation, increased migration of the podocytes, proteinuria, and therefore abatacept basically blocks this pathway and can prevent the fusion of the podocytes and the proteinuria. Certainly this would be great because we have CTLA-4 Ig is already available as subcutaneous formulation for rheumatoid arthritis, and belatacept, of course, we use it in transplantation. Well, unfortunately, again, nothing is as simple as that. We stained a bunch of biopsies, many biopsies, with FSGS and recurrent FSGS. Dr. Zoltan Lasik did the study, and we did not find B7-1 upregulated. And Dr. Remuzzi just recently wrote an article to the New England Journal that published a paper, said that he had similar experience. He did not find B7-1 upregulated in FSGS. We do find it in membranous cell, but we don't find the B7-1 actually upregulated in the podocyte. So this whole issue remains to be determined. So, you know, every year I come here and give you talks about immunosuppression, and you say, when will one day this end? Well, maybe it will. And you know, this is from The Economist. So this whole technological disruption may be occurring faster than we think. And the whole, you know, 3D printing and bioprinting is becoming a reality. This issue of The Economist actually had print me a Stradivarius. So I had Peggy remove the Stradivarius and put a kidney. And I think while she was doing it, she was like giggling at me, like, what are you thinking now? You're going too far. And in fact, then I gave her a press release from a company called Organo Novo that announcing that in 2014, they're going to print the first liver. So as I said, you know, these are technologies that are around the corner, but this corner is not as far as you think. And so maybe the day when we can print a kidney, we don't have to worry about immunosuppression, and maybe finally we can resolve the issue of organ shortage. Thank you. I'm happy to answer any questions you may have. Yep, go ahead, Raja.
So if the liver transplant, most of the livers are established from tolerance. So do you think the T regulatory cells play some role in liver transplant?
Yes. Well, I'm glad you answered this. The question was whether Tregs can play a role. Liver transplant, by nature, are tolerogenic. I always ask my fellow on rounds, I said, if you have 100 patients, kidney transplant patients on immunosuppression, and you withdraw immunosuppression, how many will be tolerant? And they usually look at me, they say, well, it's a trick question. I tell them, I know. They say, some say 20%, 30%. I said, how about less than 1%? I think natural tolerance in the kidney occurs in less than 1%. Now, if you do the same thing with liver, I mean, not right away after transplant, late, some figures have been between 15 to 20%. So Sandy Feng, in fact, is starting a study in children after liver transplant, whereby she is going to be infusing Tregs and trying to withdraw drugs. And so I will understand the mechanism of action better once we see whether, in fact, this will facilitate the establishment, whether, first of all, it plays a big role in tolerance and whether it can facilitate the induction of tolerance. But in previous tolerance signature in patients with liver transplant, even in kidney, in the few patients with kidney that you find that they have stopped their immunosuppression, they're doing well. The signature there was not that of Tregs. It was of B cells and so on. So it's unclear what role do they play, at least in this type of tolerance. But maybe if we induce active tolerance with Tregs, then this form of tolerance will be dependent on Tregs. But as it's shown in many experimental models, you really need to deplete the effector space, a T cell space, in order for the Treg to be maximally effective.